Hey guys, I'm Raph.
And I'm
On
James,
today's episode,
the Psychiatrist's Guide to
Anorexia Nervosa.
Yes! Knew it!
Which
I'm a
was-
doctor, mother grabbers. Every provider at...
I'm going to tell you a story.
Okay.
So young James is working in the emergency room.
Mm-hmm.
Her 13-year-old girl comes in. Her name is Stephanie.
Okay.
And she is brought to the hospital because she's been confused and just acting strange.
Okay.
So, of course, they consult psychiatry to
Sure.
come see her. And then James walks up to the bed and the girl stops what she's doing and suddenly starts shaking. Her whole body is shaking. Arms, legs. You start to see foam coming from her mouth. She wets the bed. What do you do?
Well, first of all, I start screaming, "Get me out of this house episode." Because somehow I've been transported into my television and I'm watching myself in an episode of House. Because it is House, I am thinking about lupus and maybe also rabies. But what would I do? I would, putting on my serious hat for a minute, she starts shaking. How bad is the shaking?
Incredibly bad. The whole body's shaking. Arms, legs, everything foaming from the mouth.
Is she conscious? If I call her name, does she look at me? Does she respond?
No.
So the first thing I would do is order some benzos. And then in reality, I would probably, let's imagine we're at one of our shared institutions that we both cut our teeth at, Hackensack, and there's one of those computers in the emergency room. I would probably order some benzos, and then I would tell the medical attending emergency provider that I believe that my patient is having a seizure and needs to be evaluated immediately.
Yeah.
But in addition to that, once everything is in motion, once she's getting attention for the seizure, maybe they're protecting her airway, and maybe they are providing other anti-seizure medications, maybe phenobarbital. I don't know what their protocol is at Hackensack. I would make sure to get a CMP, as well as a CBC and a bunch of other stuff.
Excellent. So 2 milligrams out of NIM, the seizure stops, another one comes on. They end up intubating and sedating her.
Okay.
And you ordered a chemistry, right? What are you looking for?
I'm looking at my eye is going straight towards potassium and sodium.
So sodium comes back as 120.
The sodium is low. I would definitely replete it, but very gradually.
So at this point, she got intubated, so she's transferred to the ICU. So young James is off the hook as far as the primary provider.
Whew.
However, a couple days later, maybe 2 days later, she's stabilizing and, they call you back. And she still can't really say much. She's still intubated, right? So you're getting collateral mostly from the family. And here's what you find out about young Stephanie. So Stephanie's lost a lot of weight. She's lost about 70 pounds in the last couple of months. Yeah.
Where did she start and where is she now?
So it's a 13-year-old girl.
Oh, God.
And she now weighs 90 pounds, right?
Okay.
So she started at kind of a higher weight, 160-ish, right?
Mm-hmm.
And she's about 5'3", 5'4".
Okay.
Because she was a little overweight when she had started losing weight, the family was initially kind of excited and proud of her, and they had been encouraging her to lose weight, and people were telling her that she looked well, but she kind of she just didn't stop losing weight.
Okay.
And so, eventually they started to notice that she was underweight, and they started weighing her regularly to try to help her kind of maintain a weight, right? And so what happened the day of presentation was that she was having her weekly weigh-in.
Okay.
And when she went into the bathroom to get on the scale, she passed out. When she came to, she was confused. She came to the hospital. And then that's when you saw her, the seizure happened, and
Like she went to the bathroom, like to change, to get on the scale?
Mom is in the bathroom, standing next to the scale, calls her into the room. She comes in to be weighed, and she just passes out.
Okay. Oy vey. Did something happen in the bathroom? No.
Something happened before the bathroom.
Before the bathroom.
Yeah.
Okay.
What do we know so far clinically?
We know that she lost a lot of weight too fast.
Mm-hmm.
In an unhealthy way. But obviously something more nefarious is going on here.
Going back to the labs, what was the abnormal lab?
The hyponatremia.
How would a 13-year-old girl get a sodium that low?
It's good. I'm stumped. And now I gotta know. You gotta tell me.
So Mom's saying you have to meet a certain weight. And she knows she's not going to meet that weight, right? Because she's been not eating, right? So what could she do to try to meet the weight?
To try to gain weight quick?
Yeah, to the weigh-in, like that day or the day before.
Drink a lot of water.
Which
I got
cause,
there.
You got it. Which can
I'm
cause
a doctor, mother grabbers.
Hyponatremia, right? Because you're drinking water, it doesn't necessarily have electrolytes in it, and you dilute blood, essentially. So she gave herself a seizure. What is the diagnosis psychiatrically?
For some of these diagnoses, the BMI needs to be taken into account. Is that correct?
That is correct. Yep.
So can I get a BMI? You said 5'3", 5'4",
So
90 pounds?
Yeah.
So that's probably below 18.5.
Why are you saying 18.5?
Because that, I believe, is the cutoff.
You're right-ish. You're kind of right. You're pretty right.
That's what I shoot for.
BMI is 15.4.
So she's low. She's unhealthy. So that on that BMI scale, that's underweight. And I think that puts her in the anorexia category. Anorexia nervosa.
Yeah, I would agree with that diagnosis. And this is a true story, by the way, the water and everything. I guess you should have known by the title of the episode, if you had gone in the future and looked.
Okay.
This is an episode about anorexia nervosa specifically.
Okay.
And what does anorexia mean? So it's a loss of appetite. The reason I pointed out is because it's a generic term, right? So, we call it anorexia, right? But anorexia could refer to loss of appetite for any reason. So the diagnosis of anorexia nervosa consists of the following: restriction of energy intake relative to requirements, which leads to a significantly low body weight. Okay. Intense fear of gaining weight. So there's a fear of gaining weight, or a persistent behavior that interferes with weight gain even though the body weight is significantly low.
Mm-hmm.
And a disturbance in perception of body weight or shape, or a persistent lack of recognition of the seriousness of low body weight. So essentially, your body weight is really low, and the fact that it's low has to do with your perception of your body, right?
Okay.
That's a simplified version of what it is.
Mm-hmm.
And there's two subtypes: binge purge type, and the other one is restricting type.
Got it.
And the way you define restricting type is by the absence of recurrent binging or purging over the last 3 months. So if they haven't binged or purged in the last couple of months. Also, you can go back and forth, by the way. So the diagnosis could change. But just currently the diagnosis is whether or not they've binged or purged in the last 3 months. And if they haven't, then it's restricting type.
Got it.
And so the reason I said you were right-ish is that there actually isn't a cutoff in the DSM-5 for anorexia. So
what?
You have to have, yeah. Can you believe it? You have have a significantly low body weight, in quotes, significantly low. And for adults, that's defined as less than minimally normal. And even more complicated, this is a 13-year-old girl. And for kids, it's less than minimally expected. So there actually isn't a cutoff. 18.5 is what the CDC says the lower limit of normal body weight, right? So if somebody's 18.5 or more, then, by broader medical terms, their body weight is normal, right? So you probably, pretty much, it won't meet criteria, theoretically.
And I mean, I actually like this because I know there are problems with the BMI as a concept. I think it's smarter to just have a less strict criteria, yeah. So
actually, the BMI is used. So again, this is for adults. We're talking about BMI. Kids is a little different. But the BMI is used in the criteria, but for severity.
Okay.
not for diagnosis, right?
Got it.
So if they're 18.5 or more, you're probably not making the diagnosis.
Okay.
If they're below 18.5 but above 17, then that's likely a mild case. Whereas in the 16s would be a moderate severity. In the 15s would be severe, and extreme would be less than 15.
That seems very I mean, I agree, but you're below 15, depending on who you are, that might in and of itself put you on death's doorstep.
Yeah.
I understand. I mean, I understand why it's important to make these distinctions, but it just seems like the more important thing might be the relative change, but I think that you're on the same page.
And no, I agree. And actually, it's in the criteria that doesn't wholly constitute the severity. There are other factors. There's kind of like a fudge factor there for using logic.
Yeah.
So going back to kids, So again, no hard cutoff, right? But again, according to the CDC, but not in DSM criteria. Below the 5th percentile. So in kids, we use percentiles for things, right? So below the 5th percentile is underweight. And so that's kind of like a number you're kind of looking at, right?
Got it.
And then the other important thing to keep in mind is because kids are growing, they actually don't necessarily have to lose any weight, right? They could, right? They could be getting taller and could maintain the same weight, but still be getting, severely underweight.
Sure.
What is the most lethal psychiatric disorder?
I mean, it's got to be something with what we were talking about. Getting eaten by a dinosaur.
Yes.
Ah,
you got it.
No, anorexia.
Anorexia nervosa is the most lethal psychiatric disorder.
Okay.
As illustrated by the case of this 13-year-old girl getting herself intubated with a seizure. The broader point is that anorexia nervosa has a lot of medical sequelae, right? Let's talk about some of them. So
let's talk.
You're in a state of undernourishment. You're not getting all of the stuff you need for your body to function, and all sorts of things can start to break down. Bone mineral density loss, which can lead to osteoporosis and stress fractures. So this is one of the things that can be permanent, because if you recall, you're supposed to get like your peak bone mineral density in like your adolescence and early adulthood, and then it kind of declines over time. So now you're interfering with reaching that peak, which means now 40 years down the line, even though you may have recovered from anorexia, you're now prone potentially to things like stress fractures, more prone than the average person.
And as a psychiatrist who deals primarily with adults, you would think that you could leverage that fact to maybe help the patient gain some insight into the damage they're doing to their body. However, we all know that especially when we're talking about kids, they can't see 40 years into the future. They can't see 20 minutes into the future. So it's frustrating that you probably couldn't leverage that to say, hey, you might want to rethink what you're doing here.
Yeah. I mean, you might be able to, but you're getting into mystical, complicated world of psychotherapy and cognitive distortions and emotional reasoning, and a lot easier said than done, especially in kids.
Very true.
Another thing, amenorrhea, which means
no periods, which means that you just run on sentences just constantly, and all your teachers are like, I can't even make heads or tails of this term paper.
Yeah. Amenorrhea actually, I think, used to be in the criteria.
Really?
Do you like that? I just ignored you.
Yeah, I do. I appreciate that. Shannon does that. My fiance does that. And it's important. I'm glad that you've learned to do that. It only took 4 years.
But I think in DSM-4 it was in the criteria, and they took it out. It's very common to lose your period when you're significantly underweight for a woman. But some people don't. Neonatal complications, if you get pregnant in this undernourished state. Stunted growth. Delays in sexual maturity. Changes in your hair, like lanugo. Hair loss or brittle hair. Lanugo, do you know what that is?
The downy hair on the arms and stuff.
Cognitive impairment or seizures, like in our case, right? Depression and suicide. Keep in mind, we're talking about the medical sequelae of anorexia. The undernourished state itself could produce depression, even to the point of suicide. Aside from whether there might be a comorbidity or whether it might cause psychological factors leading to a depression. Dehydration, hypothermia, respiratory failure. So pretty much all parts of your body could stop working, right? Because you're not...
Very, very deadly stuff, as you pointed out.
There is something called refeeding syndrome.
Yes, and refeeding syndrome is when you are recorrecting the weight deficiencies, but you don't do it in a measured way. And that itself leads to electrolyte abnormalities.
You're exactly right. So when you're rehabilitating the person nutritionally, if you do it too aggressively, it can cause fluid and electrolyte shifts in and out of the cells versus the bloodstream, which can lead to organ failure, especially heart failure, because that's usually the most deadly. And the way it's characterized clinically is by hypophosphatemia. So if the phosphate is below 2 milligrams per deciliter, another way it would look clinically would be edema. Somebody's undernourished, you're refeeding them, you do it too aggressively, then they start to look really super swollen and the phosphate is low. It's refeeding syndrome. So we have an idea what anorexia is. We have an idea why it's super dangerous and actually the most lethal psychiatric condition. Let's talk a little bit about who gets it and why. The lifetime prevalence of anorexia nervosa is somewhere between 0.5 and 1%. It's 10 times more common in females than males.
Wow.
Yeah, it usually arises in adolescence or young adulthood, and it has a long-term mortality of 10 to 20%.
That is staggering. Wow.
What model should we be looking at to understand psychiatric conditions generally?
I feel like this is going to be an obvious answer, but I don't know what it is. I don't know what you're getting at.
The biopsychosocial model.
Oh, of course.
So, biologically, there are genetic risks. If a first-degree relative has anorexia, then you're at increased risk. Psychologically, there are temperamental risk factors. So, someone who has an anxious temperament or an obsessive temperament is at risk for developing an eating disorder. The binging and purging, if you have that type, is associated with other impulsive behaviors. And environmentally or socially, risk factors include a society that values thinness. So you might be at even higher risk if you're engaging in activities like modeling, acting, dancing, or in certain sports like gymnastics, figure skating, wrestling, or boxing.
So or just being a young person in America. Exactly. And like
or having Instagram or TikTok.
Exactly, yeah. You know what just struck me is that, whenever we're looking at the biopsychosocial model and we're looking at the risk factors for certain things, I just gave a talk on ADHD and internet gaming disorder and stuff like that. And, in terms of temperament, it's always like, if you're a type A person, if you're very detail oriented and obsessive, that's not good. And you might be at higher risk. I wish there was at least one mental illness that I could point to that I could say, yeah, if you're a really laid back, chill dude, you're at risk for this. Because there isn't one. It's always the high-strung people. I can't think of a single one that's like if you're a laid back, roll with the punches kind of person. It's always like if you're high-strung, this is what I'm best at. I derail you.
Yes.
The train's going strong. There's coal in the engine. We're going choo choo choo, and then I'm like a big giant. And I just rip up the track. And then I laugh maniacally.
I need to draw that and put it on the cover. So, looking at those kind of risk factors, let's look at some diagnostic clues that you might find in someone who has anorexia.
Okay.
So, temperamentally, somebody who's a perfectionist, who can be obsessive, or who has shown extreme self-discipline. So if you're seeing someone who exhibits those kind of traits in other areas of their life and behavior, then this is a person who's at risk for having anorexia. Stressful life events can be precipitating factors like starting high school or starting college or bullying.
Psych resident.
Yeah. Illness or loss of some sort of trauma. An objective sign that someone could have anorexia would be ritualistic or peculiar eating habits. Someone who suddenly starts showing excessive interest in food. Someone starts exercising and might be overdoing it a little bit.
Got it.
And there's a concept of the anorexic voice. A lot of people who suffer from anorexia nervosa will have this what's been termed the anorexic voice, which is like this constant inner monologue of criticism and lies, particularly focused on the body, self-image, and food.
Fascinating.
Some differentials for anorexia?
You could have some sort of various medical illnesses, diabetes. You could have other derangements in terms of, pancreatic function, all sorts of good stuff.
Hyperthyroidism, malignancy, a GI illness, another eating disorder, substance use disorders, right?
Mm-hmm.
The person could be losing weight because you're using cocaine all the time.
Yep.
Or maybe
no
they're
desire to eat.
Using stimulants not prescribed to them.
I think that's an interesting point, and I just want to highlight that too, is that, eating is an inherently pleasurable experience. And I think that should I ever come across a younger patient or an adult patient who seriously has this mental illness, you have to think about what would it take for them to forego that pleasure. It would take a lot. And it's, whenever we learn about substance use disorders, you always look at the degree of activation of the dopamine receptors in the brain in response to various things. And, food saturates it so much and sex saturates it a little bit more, but then heroin saturates it 1,000 times more than that. You have to realize that there's a biological tide that the person is going against to achieve these ends.
It's theoretically inherently pleasurable, but for someone with anorexia, it's probably not, right?
Yeah.
So think about the distortions that have to be present in their mind.
Yeah.
Treating anorexia. One of the first things you have to determine is where do we treat this person, right?
Mm-hmm.
The very first thing you have to figure out is, does this person need to be admitted to the hospital to be stabilized medically? There are some common admission criteria. Most of my exposure in child and adolescent psychiatry to eating disorders is on the pediatric floor, so the kids get admitted
Gotcha.
for treatment or observation. And some of
that's just fascinating to me because again, we don't see it. I've seen maybe once, but you probably see it all the time.
I do see it all the time. Some of the common admission criteria would be unstable vital signs and arrhythmias, or other signs of severe organ dysfunction like syncope, seizures, and then obviously other organ failure like cardiac failure, hepatic failure, pancreatitis, hypoglycemia, electrolyte disturbances. So these are the things you're kind of looking for to determine, does this kid or adult, before we start tackling this eating disorder, do they need to be admitted to the hospital, to the medical floor to be stabilized? I guess the next step in figuring out where to treat them is, do they need to be admitted to a psychiatric unit? Right? So once they're medically stabilized, does this person have suicidal ideation? Or is there another reason that they need to be admitted to a psychiatric unit for psychiatric stabilization? The next step would be stepping down to treatment specific for an eating disorder, right? Mm-hmm. So does this person need to go to an inpatient eating disorder unit somewhere? Or can they do a day program or an intensive outpatient program or just regular outpatient care?
Got it.
Yeah, I see most on the pediatric floor, and then I see a handful. There's always a handful on the psychiatric unit, but generally they're admitted, for suicidal ideation or something kind of related, right? Not specifically for the eating disorder itself, right? Because if we're treating them for the eating disorder, then we're referring them to some sort of specialized treatment center for the eating disorder, whether it's inpatient or outpatient or otherwise. So anorexia is notoriously difficult to treat. You definitely need a multidisciplinary team. People you might want to have involved are the primary care provider, an eating disorder specialist, like a clinic or an inpatient unit somewhere. You might want to have them involved, so at what point this person needs to go there, that kind of thing. A psychiatrist is usually part of the team, a therapist. You should probably have a nutritionist on board, and probably a family therapist as well, because there's usually a lot of family dynamics going on. And even if there's not underlying causative family dynamics, which I don't know if that's even possible, but even if there's not, usually the family needs to be involved in the treatment for the person to get better.
Sure.
How do you treat it specifically?
From my little experience, I do know that, generally speaking, I feel like it's one of the few disorders that providers who are familiar with this will tell you that treatment is hard, right? It's not like there's a magic bullet. There's no one thing. It's not like, you're hearing voices. This antipsychotic is likely to at least help, And I feel like what I hear is that it's a combination of a bunch of things, and that success rates are relatively low, and whatever gains you do get are hard won, and difficult to maintain. Is that true?
Yeah, I think that that's pretty accurate. How effective are medications for anorexia nervosa?
I mean, I would say if as monotherapy, probably not. But
Right.
as combination therapy, probably enough to warrant their use.
I guess that's probably the way that I would put it. So not very effective, but yes, they could be warranted.
Gotcha.
But the standbys really for treatment are going to be nutritional rehabilitation and psychotherapy.
Gotcha.
There's a couple of types of psychotherapy that have been shown to be effective in anorexia. Family therapy, broadly speaking, CBT, psychodynamic psychotherapy can be effective. Motivational interviewing has evidence base for anorexia.
Cool.
And there's actually a specific type of therapy for anorexia nervosa. There's a type of therapy called the Maudsley method. And
I've heard of this.
yeah. So the Maudsley method is a type of family-based therapy that was developed in the UK. I believe this is a psychiatric hospital that it's named after.
Got it.
Which I think in turn was named after a psychiatrist from like the 19th century. But anyway, they developed a type of therapy that's used around the world, including specialized centers in the US. And the philosophy of the therapy is, first of all, it's a family-based treatment. It doesn't assign blame to anyone.
Okay.
Or to the family, but it identifies the family as the best source of treatment
Okay.
for the patient. You know, some of the things it does is empower the parents to be involved in the treatment. It externalizes the illness, and it's, I think, well known for a concept of the family meal, where a therapist will actually sit down and have dinner with the family and kind of observe the family dynamics during the meal.
You know what's so fascinating is that as we've been talking about this, you know what? No one conceptualizes, or I don't, and as far as I know, not many people conceptualize this disease as an addiction. And yet, so much of what you say is just reminiscent of everything that I know about addictions, including you can only go so far in a hospital. And the way that you're really going to make lasting change is to rewrite the person's daily routine in a way that helps them avoid, whatever is addicting. And it just, there's so many things that you've said throughout the episode today that really make that connection for me.
Yeah, absolutely. And I think the same hardware, neurologically speaking, is involved in anorexia and in other similar kind of disorders. And it's a parallel that I've seen drawn with other kind of behaviors like cutting or other forms of self-harm. It can become addicting and, can release endorphins and, kind of like hijacks the reward pathway.
Sure.
In a way that's completely destabilizing for the individual. So there's 3 phases to Maudsley therapy. Phase 1 is weight restoration. Phase 2 is returning control back to the patient.
Okay.
Overeating. And finally, phase 3 is helping the patient establish a healthy identity. So maybe a more kind of traditional psychotherapy techniques, right? So,
got it.
And then medication-wise, what would you not use?
Bupropion.
Contraindicated in somebody with a history of seizures, or in this case, a history of an eating disorder. Another thing to consider is cardiotoxicity, right? So one of the things that you're really worried about is, arrhythmias and heart failure. And a lot of the medications we use are cardiotoxic in some way, such as QTC prolongation with antipsychotics or tricyclics, which can also cause cardiotoxicity. What do you think is one of the most common medications used? So Zyprexa is really commonly used for anorexia. Again, in and of itself, it's not that effective, but one of the side effects is weight gain. It can also sometimes really help unstick people who are stuck with like severe cognitive distortions and anxiety.
I know it's used that way, and I know that antipsychotics in the child world are used for non-psychotic reasons all the time, but it still seems like, especially as someone who does not have specialized training, it seems like such a big gun. And it seems like the possible downsides are so many. I'm sure it does wonders, and I'm sure that's why it's used. But it's like, as a non-child psychiatrist, it's kind of a tough idea to think about prescribing a child Zyprexa if they don't have a psychiatric disorder. But I'm sure that you've seen it turn people around.
I have prescribed Zyprexa, not a lot for kids. Like I try to avoid it, but sometimes you have to, and the benefits can outweigh the risks. But I mean, especially in this case, we're talking about, again, the most lethal disease in psychiatry, right?
True.
So big guns are...
I think it's internet gaming disorder, but agree to disagree.
All right, we'll talk about that again in another episode. And also, if a lot of the side effects are from weight gain, and in this case, the person is severely underweight, right? So it kind of counteracts that.
Sure.
Certainly, if the person has like a coexisting other psychiatric condition that might respond to medication, that might make sense. And for some people, it can do wonders, right?
Yeah. Very true.
But certainly a multidisciplinary, multi-pronged approach, ideally involving the family, is going to be the answer. And that's all I have to say about anorexia nervosa.
I have learned so much. I'm ready to get out there. I'm going to start prescribing Zyprexa left and right.
Yeah, you might as well.
Just gotta get used to it. Gotta kind of break that seal.
You know who's really going to love you?
Every provider at... No, I don't.
No.
I don't.
Pretty much every medical doctor, every hospital, endocrinologist are going to love you. Nutritionists are going to love you. Zyprexa can be a wonderful medicine in certain instances. Here's the top 5 things to know about anorexia nervosa. Number 1, anorexia is the deadliest psychiatric condition. It has a lot of life-threatening potential medical sequelae and needs to be treated appropriately.
Number 2, to make a diagnosis of anorexia in children, there are no strict cutoffs, and where they are in terms of weight in comparison to where they came from may be more important than the raw numbers.
Number 3, risk factors for anorexia nervosa can include temperamental, environmental, and genetic risk factors. People at risk might have an anxious or obsessive personality. They might have other impulsive behaviors in their life, and they may be in a particular society or environment that values being thin. Activities like modeling, acting, dancing, or sports like wrestling, boxing, gymnastics, or figure skating, and, like we said earlier, nowadays, just having social media.
Number 4, treatment for anorexia nervosa is difficult, hard-fought, and often the most effective therapies involve the family.
And finally, number 5, although it's a potentially lethal condition that's difficult to treat, there are a lot of very effective treatments out there. There are specialized treatment centers. There are specialized forms of therapy, such as the Maudsley method. If someone is suffering from anorexia nervosa or another eating disorder, there is hope and it can be treated.
We like to end every episode by saying that if you yourself are struggling with mental illness, whether it be an eating disorder or anything else, depression, anxiety, you should know that help is out there, and getting help is not a sign of weakness. It is often a sign of strength. A couple ways that you can get help if you're really hurting right now and you need to talk to someone right away. 1-800-273-TALK is the U.S. nationwide hotline for suicide prevention. And if you would like to get established with a mental health professional, you can go to Psychology Today, you can go to the American Psychiatric Association website, and you can also check your insurer's website, if you have insurance, to see providers in your area that accept it.
And remember, psychiatric conditions are medical conditions and neurological conditions that can be treated. So, until next time.
Adios.
Peace.